Progesterone is easy to explain badly. The bad explanation says progesterone maintains pregnancy, so give progesterone to prevent preterm birth. That sentence is smooth, and it is dangerously shallow. It makes progesterone sound like a general pregnancy glue. It hides the actual biology, the route of administration, the target tissue, and the reason treatment may work in one phenotype and fail in another. The better explanation begins with the parturition system. Birth is not only uterine contractions. It is coordinated change across the myometrium, decidua, fetal membranes, cervix, inflammatory signaling, extracellular matrix, and endocrine receptor biology. In term labor, this system activates at the right time. In spontaneous preterm birth, part of this system activates too early. The cervix is not a passive plug. It is a living connective tissue structure. It remodels. Collagen organization changes. Water content changes. Inflammatory mediators change. Matrix metalloproteinases, prostaglandins, interleukins, and local immune cells become part of the story. A cervix that shortens on ultrasound may be showing us early remodeling, occult inflammatory activation, mechanical stress, infection-related change, congenital weakness, or some mixture of these. This is why the phrase short cervix is a signal, not a full diagnosis.
Progesterone is biologically plausible because progesterone signaling helps maintain uterine quiescence and modulate inflammatory activation. In the myometrium, progesterone action can oppose pathways that increase contractility. In decidua and membranes, progesterone-related pathways interact with inflammatory mediators. In the cervix, progesterone can influence remodeling and inflammatory signaling. The literature around the pregnant trial and later meta-analyses repeatedly points toward this set of mechanisms: local progesterone action, functional progesterone withdrawal, inflammatory signaling, and cervical ripening. Functional progesterone withdrawal is an important phrase. In humans, labor is not explained simply by a dramatic fall in serum progesterone. Instead, tissues can become less responsive to progesterone action. Receptor isoforms, inflammatory transcription factors, prostaglandin pathways, and local tissue biology can shift the balance toward labor, even while circulating hormone remains present. So if we give exogenous progesterone, the question is not only does the blood level rise, the question is, does this intervention alter the local biology that is driving this patient's pathway toward early birth? That question already tells us why route matters. Vaginal progesterone is not the same intervention as intramuscular 17-alpha-hydroxyprogesterone caproate. The route, molecule, pharmacology, tissue exposure, and evidence base differ. A resident should never store them under one vague mental label called progesterone.
When a trial uses vaginal progesterone gel, 90 milligrams daily, in asymptomatic singleton pregnancies with a cervical length of 10 to 20 millimeters, that is a specific intervention. When another trial uses vaginal progesterone capsules, 200 milligrams nightly, in patients with a cervix of 15 millimeters or less, that is also a specific intervention. When Meese used weekly intramuscular 17-alpha-hydroxyprogesterone caproate in women with a prior spontaneous preterm birth, that was a different clinical question. Mechanism helps us remember the distinction. Vaginal progesterone belongs most naturally to the sonographic short cervix phenotype because the cervix is part of the target biology. Intramuscular 17-alpha-hydroxyprogesterone caproate was studied historically in the recurrence phenotype. The two should not be interchanged simply because both contain progestational language. Now, we need to be equally careful in the other direction. Mechanism is not proof. A biologically beautiful mechanism can still fail in a clinical trial if the phenotype is wrong, the timing is too late, the endpoint is insensitive, the dose is inadequate, the pathway is not progesterone responsive, or the patient population is too heterogeneous. Spontaneous preterm birth is a syndrome, not one disease. That sentence matters. a syndrome can have several roots into the same final event. Imagine 3 patients with short cervix. In the first, cervical shortening may represent a progesterone-responsive inflammatory and remodeling pathway detected early enough to interrupt. In the second, the short cervix may reflect mechanical cervical insufficiency or established dilation. That patient may need a different course entirely. In the third, the cervix is first found short at 30 weeks. By then, part of the extreme preterm endpoint has already passed, and the biologic process may be too advanced or too close to normal late pregnancy remodeling for new progesterone initiation to matter. Same ultrasound phrase, different biology, different evidence. This is why mechanism should make us more precise, not more reckless. The teacher's role for this course is use mechanism to explain why an evidence boundary exists, not to erase the boundary. Progesterone's anti-inflammatory and cervical effects help explain why vaginal progesterone can reduce early preterm birth in mid-trimester short cervix. They do not prove that starting treatment at 32 weeks will prolong pregnancy. They do not prove that a patient with prior preterm birth but normal cervix should receive vaginal progesterone. They do not prove that 17-alpha-hydroxyprogesterone caproate and vaginal progesterone are interchangeable. Store the mechanism this way. First, the cervix is a continuous performance organ, not a binary plug. Second, spontaneous preterm birth is a syndrome, so the same sign can arise from different pathways. Third, vaginal progesterone is a route-specific intervention aimed at local parturition biology, especially cervical and inflammatory pathways. Fourth, mechanism supports the trial evidence, but the trial population still governs the clinical claim. That is the kind of mechanism worth remembering. Mechanism that changes what you prescribe, what you refuse to overgeneralize, and how honestly you counsel the patient.